Aloha, I am Mark Alexander, Executive Director of the Hawaii Medical Association. Welcome to this edition of Conversations at HMA, a program during which we feature physicians and other leaders in the community discussing healthcare issues impacting Hawaii. This evening's edition is entitled 2026 Legislative Wrap-Up. Before introducing our guests for this evening, I'm going to go over a few of the logistics. For those who are participating via Zoom, we ask you to engage the conversation by submitting your questions, comments, any issues using the Q&A function on the Zoom webinar program. We will try to feature as many of these as possible during our program. In any event, all the questions and comments that are collected will be shared with our panelists. For those that are in the room, we invite you to submit your questions, issues, and comments, again, using the index cards, and give them to either Mark or myself. And we will try to, again, feature those, and then, again, we will compile them and share any questions and comments with our panelists. We have a very distinguished panel, again, this evening for our discussion. It's my pleasure to introduce them. We have Mr. Michael Robinson, who is the Vice President for Government Relations and Community Affairs for Hawaii Pacific Health, HPH. We also have Mr. Jacce Mikulanec, who is the Director of Government Relations for the Queens Health Systems. And we also have our own HMA Chair of the Public Policy Committee, Dr. Elizabeth Ignacio, who is also an interventional radiologist. It's my pleasure to introduce our panelists and turn this over to Dr. Ignacio.
Great. How's this audio? Sounds good? Okay, good. Well, let me get my slides going. Thank you, Mark. Aloha and good evening, HMA. We've had some good HMA conversations, these events in the last 3 to 4 months. And I do hope that in this conversation, we can review a few bills and debrief on some of the policy proposals with our guests. I'll set the stage by stating that this 2026 legislative session included several very challenging and emotionally charged issues for organized medicine and Hawaii healthcare. And for those reasons, I'm especially grateful to have Jacce Mikulanec and Michael Robinson join us tonight. Thank you guys for being here. They both have deep experience navigating the legislative process, and they worked collaboratively on many of the healthcare issues over the years. I'm looking forward to an honest discussion about what worked, what did not work, and how we can continue to strengthen our physician advocacy and Hawaii healthcare moving forward. So I have to say that, in addition to engaging on several high-profile scope and workforce debates, HMA also maintained a lot of work on our practical measures that directly affected patient care and physician practice in Hawaii, including issues like cancer screening and prevention, air medical transport, workers' comp, continuity of care, and rural access challenges. So I'll ask the first question to Jacce because we have that list that's there on the screen. We're going to jump around to some of these measures, but Jacce, as the Director of Government Relations for the Queens Health Systems, from the hospital system perspective, please tell me what your thoughts are on big and small issues of these healthcare bills, and how did aeromedical services, for example, how did that fall as a priority for hospitals like QMC?
Sure. That's a great question. It's a great issue to start with, too, because it's been such a challenging issue for our state over the last, 5, 10, well, forever, really. Being an island state presents a lot of challenges. For Queens in particular, we received the bulk of high trauma cases from, all over the state of Hawaii, everywhere. But specifically, for Molokai, it's been an ongoing challenge. Every session when I see Linda Coit, she's like, "What are we doing about air, medical transport?" And the precariousness of air transport between the island and Oahu is it's magnified, year over year. I think over the last 2 or 3 years in particular, I think the Department of Health and all of the stakeholders have really come together via several different resolutions and so forth to convene working groups to look at this issue in particular, and to look at our partner states and other jurisdictions to inform on how we can kind of address this issue better. We've looked at Alaska, we've looked at some rural places like Montana and Washington State, and looked at ways that we can kind of not only do better, but also pay for it in a way that's going to make sense, right, for our overall health system. So I think because of that work that's happened via different resolutions over the last couple of years, I think this year the department and the different health chairs said we've got enough information to establish a new office, a new director, and really take some formal steps forward in fixing this problem that's facing Hawaii. And I think the right stakeholders at the table to make real change finally. So I don't know, Mike, from a Kauai perspective, you have.
Yeah, no, I have we have a very similar perspective too, with Kapiolani Medical Center being a tertiary center. We get a lot of transports for a lot of our pediatric cases, as well as on the island of Kauai. I think that, and we've had some tragic outcomes in the past in air medical transport with some unfortunate crashes that have occurred. I have to give a lot of credit to Department of Health for really making this a priority. This has come up, I know, Director Fink has brought this up a couple of times over the years, and the stars really aligned this year, as Jacce mentioned, in terms of the stakeholders. And I think most importantly, the funding, right? Because this bill actually provides stable funding from the state for, I believe it was 4 FTEs, which is a significant commitment for the state to do. And it really takes that level of kind of prioritization, and it all came together this year, and we're just happy when it happens, and it happened this year.
The other kind of nice thing about this was I think all of the groundwork that was laid over the last several years you had people from the federal government, the county level, state, everybody was kind of bought into this. So I think when you have good legislation passed like this, it's usually because you've laid that really good groundwork for years before. So
it was really tough because after COVID, we sort of uncovered how challenging it was to transfer patients from the periphery, from our neighbor islands to Queens and to HPH. And then we had these catastrophes with the Lahaina fires, and more recently with the flooding and the Kona flooding that happened, and having to move patients, for example, from Maui over to Queens and to the island of Oahu. So I really feel like there was this no, 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 then yes, yes. And it's really also a timing thing. It's been so interesting for me to follow the legislature and their thinking, because all of these priorities are moving and changing in real time, and following the dynamic discussions that are occurring between all the stakeholders and what is needed. This didn't just pop up overnight. It wasn't like something that just popped up like last year or anything. It's been years of bringing back different reports from different areas and bringing all sorts of patient interest groups together on the topic. So I'm really grateful that that moved through. HMA stayed with that one, and we kept pressing forward. And I was very excited when it really started to move mid-session. Yeah. Thank you. Another set of measures that sort of bread and butter and addressed a lot of our patient-facing issues was workman's comp. Now, HB 1514 and 1515, they were workman's comp bills that the first one would define deadlines, refine the process for vocational rehabilitation services. That was transmitted to the governor April 30th, so that's very exciting. And HB 1515, also a workman's compensation bill that would expedite the functional capacity examinations that are ordered by an attending physician. That was also transmitted to the governor on May 7th. So this included work groups led by lawmakers like Representative Scott Matayoshi, and took some years to get across the finish line. In many ways, I think some of these smaller or more targeted efforts are where organized medicine can be really impactful. And it really changes for patients and physicians the day-to-day operations. So I think it's not always generating headlines, I guess, but they do matter deeply to our communities and practice throughout the islands. Another bill that I think was similar was SB 3324. We knew that a lot of things were going to a lot of Medicaid programs were going to struggle and that we were going to try to find funding for these. And I was really excited that the home and community-based services was getting good support during this legislative session. In Hawaii, the care needs are growing. We have a lot of unmet demand and persistent waiting lists for in-home services. So HMA supported this measure all the way through, and we were able to support smoother hospital to home transitions. Lots of good synergy on this one. It included Department of Human Services, AARP, DOH, SHPTA, Disabilities and Communication Access Board, and Aloha Care. That one was enrolled to Governor May 8th. So we did make some really good substantial wins there. I'm going to switch gears a little bit for SB 3132 because I want to hear you guys' perspective on how that information came, how that bubbled to the top for you guys. That was the syndromic surveillance measure, and we're so grateful for the guidance of DOH, including Drs. Fink and Dr. Sarah Kemble. There was some good support from SHPTA and HAH. Michael, can you share the hospital's perspective on this one?
Well, I'll be quite honest, being a non-clinical person, until I was talking to Dr. Kemble, I didn't even know what a syndromic surveillance system was until she talked about it here when we were sitting around. And, luckily, again, I think kudos again to the Department of Health. They had socialized it with the Healthcare Association. And so after that meeting that we had here, I did go back to our chief quality officer, and it was like of course we're going to support this. And I think what's really interesting about this piece of legislation is that we're seeing a lot more of this type of work that the state is having to do, right? As the more that the federal government has kind of withdrawn and is really redefining what their role has been in public health, the states are having to come back and pick up where that need was basically vacated.
Yep.
And that's a very common theme. You're gonna see this across a number of bills that came up this session, and this thankfully again was prioritized by the department. And from a workflow perspective, it seemed like this is something that we're already doing, and it's definitely something that our physicians in our emergency rooms rely upon. So it was not a very difficult decision for us to support this at every hearing.
And similarly, on the fingerprinting measure, the HB 2576.
I don't know, Jacce, before we get into that, did you want to share anything on syndromic surveillance?
Please.
No, I think Mike handled that well, and I'm going to defer to Mike on the fingerprinting as well and add in commentary as needed.
Yeah, no, the fingerprinting bill, it was a very confusing bill, and I think it also it speaks to the fact that if you want to really get complex activity done, you cannot just do it on the fly during the legislative session. It really takes a lot of conversation and cooperation and discussion with other stakeholders. And in this case, fortunately, we had began this conversation with the Department of Health, Office of Healthcare Assurance, going back, I think it was like August or October. And essentially, in a nutshell, there's a law that was on the books that required that if you had direct patient access in a hospital or in any setting essentially that the department licensed, that direct patient employee was required to undergo FBI fingerprinting as part of the background check. So this was a law that was on the books for probably 15, 20 years. However, it wasn't enforced until probably the last couple years. And it was rolled out kind of systematically, first with the post-acute care partners, and then it came to us at our ASCs and our acute care hospitals. And that's where it came to the attention of Queens and Kaiser and HPH and Castle. And we thought we recognized that if we had to do that, it would be quite disruptive from a workflow perspective.
And costly.
Because the way that it was set up, it would be required that physicians, and basically if you weren't fingerprinted, you basically have to get it done through a vendor that was chosen by the department. It was about $75 a pop. And for a lot of physicians, the thought of that was kind of scary, because the way the algorithm worked, it would take that person back to any infraction that occurred to the age of 18. And in our state, we actually have protections in our statutes that you cannot deny employment or either a prospective employee for if it's a felony, you can only look back 7 years. If it's a misdemeanor, it's 5 years. And on top of that, that job needs to be rationally related to the infraction. And so things like, maybe a DUI that somebody had, you would have to basically demonstrate that that infraction occurred outside of that time period and was rationally related to that job. So you can imagine that for a lot of folks, if you had an algorithm that did not maybe take that into consideration, it could cause disruption. And given the workforce challenges that we have today, we saw that as a problem. So we were really grateful again that we were able to work with the department, and we wound up with a bill that essentially exempts physicians that are working or employed within an acute care setting. But then in addition to that, if they've gone through the credentialing process, they are also exempt from this requirement, as well as students and residents and volunteers, which without this bill, technically they would have had to gone through the same process. So again, a big win for I think a large chunk of the employer group. There's still some fragments left in the post-acute care that, I think we need to figure out from a public policy point of view whether that needs to apply to them. But we were really happy to get that passed, but then having to explain that to colleagues in HMA or other folks
Or legislators.
you can imagine how difficult something like that was, and that's why I think it was a lot more difficult to pass than we had expected.
And the only thing I'd add on is, I think even the Department of Health maybe didn't understand the intended consequences that this would have on our systems and the other providers within the community. But I think once those concerns were identified, the collaboration that eventually took place with the different state agencies was really paramount to getting this bill through and over the finish line. So really appreciated that greatly.
What I observed when we were talking about that measure was a lot of intense conferencing. Like, it was very good to know that everybody was talking about it and trying to come to some agreement. And I appreciate so much that you guys were reaching out to our different partners and we were able to give input into our perspective for independent physicians, for example, in that who would not be necessarily credentialed at a hospital, but will be having to do the fingerprinting for acute care or a surgical center or someplace where they do procedures. So I think that was very exciting to see, but also, it was a lot of intense work that maybe could have been done a little bit earlier. I do wonder, when it seems that a lot of these measures, you have a very cohesive hospital mindset. So there's definitely, you guys are moving together and discussing priorities in advance. Can you talk a little bit about that process and how you guys collaborate off season?
Well, I think that's one of the things that the hospitals do really well, and our providers do really well. Whether it's through HAH and what we have an advocacy committee where we're all represented on, and we vet different issues on a really regular basis. Or just within, Mike and I and Kaiser. I mean, we're on this is probably too much information, but we're on a text thread, which now at this point is voluminous. But we do a lot of really, personal vetting of things, right, for our organizations, and then help bring them to advocacy committee, and then bring them to, the groups like this. And I think the trust that we have. The interest we have in overall health in the state of Hawaii really drives what we do. And it's why I continue to work in this space, because it's unique, I think, in some ways to this particular industry. So,
yeah, no, that's right. I agree with everything JC shared. There's a lot of trust between us. There's also, I have to give the Healthcare Association a lot of credit for this. Hilton Rathel and Paige Heckathorn, they're an amazing team. They do so much of the work in building consensus. The Healthcare Association actually represents the entire continuum from acute care to skilled nursing facilities to home health as well. I think within the acute care group, there's probably, because there's less of us, there's probably a lot more less kind of dispersion of interest, right? We're pretty coalesced around a lot of things that hit us commonly, whether it's workforce, licensure, fingerprinting for sure was one that was very easy. And I think we have also that as a benefit is that we're all nonprofit healthcare systems. And even that in itself, I think adds a lot of commonality in terms of goals that you don't even find in other states where you've got a provider network that's comprised of both for-profit and nonprofit organizations. So just coming out of the get-go, there's that kind of built-in cohesion. And then just over time, we have a lot of trust and respect for each of our institutions.
I'd add on also that within, our little group of hospitals and so forth, we all bring kind of different skill sets. And I think when you're doing any kind of advocacy, that's really critical. Some of us, like myself, have worked within the state capitol and have worked for politicians. Other folks have worked, exclusively in the hospital, setting and so forth. Other folks have done, nonprofit work in other industries. Having that multifaceted kind of hui together that can work on behalf of these issues is, I think, really essential and why we have a lot of strength.
That's wonderful. And I think that HMA is getting better. We're getting stronger. We're working those muscles. We are collaborating more with primary care and pediatrics, family practice, as well as our specialists. So internally with our physician groups, we're doing similar, but we want to reach out more and create more lateral connections with our hospitals, with the other patient interest groups, so that we're all kind of moving in the same direction and things aren't catching us so much by surprise when they happen in the legislature. So we're working on it. And I think that's a good transition into some of these more difficult measures that we might talk about. We want this discussion to be candid and constructive. And there were some measures that, for HMA, the outcomes were not super great. That included SB 847 on psychologist prescriptive authority, SB 2491 on the qualified healthcare provider, and HB 1970 on the UH Cancer Center tumor registry. And I'd love to hear, this could be a good opportunity to review, what happened legislatively, but also to reflect kind of on our strategy and, a little bit of Monday morning quarterbacking. Please be gentle. But what are your thoughts, for example, on psychologist prescriptive authority? Any lessons learned or hints or?
I'll start first and let JP
Sure.
finish up. Honestly, in Hawaii Pacific Health, when it comes to behavioral health and mental health, we aren't out in front and center because we know there are other providers like Queens and Castle that are really on the front lines of this. We got involved in this at the tail end of this only because the pilot wound up on Kauai. And when it wound up on Kauai, then it was perceived as being an interest. And even then, at the end of the bill, if you notice, we wound up where it's on Kauai, but it's limited to patients that are under the care of an FQHC. So again, that doesn't even involve Wilcox or Kauai or frankly, even HHSC, the state hospital system. And I think the only thing I, had shared with, and I got to say, this was one of the most important bills between the House and the Senate. And so all these other bills that we're talking about that were a success, they would not have been a success unless this particular bill there was agreement on. And I think that's always eye-opening for us when we find that bill that is of so much interest between the two chambers that nothing gets resolved until a particular bill. And this bill was that bill in the healthcare space. And so we were really motivated to make sure that it got resolved because we had all those other bills. And I think the one thing I added, from the Hawaii Pacific Health side, we did not take a position on it. But we don't have we certainly understand the crisis that our entire state is facing in terms of availability of service. There's no arguing against that. I think it didn't bubble up in our area. We quite frankly have not had psychologists that are employed by us or part of our primary care team bring up prescriptive authority per se as the one thing that they felt that needed to be addressed. So where that need is being expressed, it is coming from outside of our healthcare system, and I don't want to delegitimize it, but I just do want to say that from a policy point of view, we appreciate what psychologists are able to bring to a care team. In our model, that skill set that's brought in is not prescriptive authority. There's a whole bunch of other training sets that they bring that enhance our care team. It's just not
Absolutely.
that. Yeah, I just wanted to say that.
I have nothing to add. It would ditto to everything Mike said, except that you start off session and you think you have a great view of the landscape and you know exactly what's going to be high priority and high topic. And then it shouldn't surprise me at this point, but it's always the bill you least expect when it comes down to conference that everything starts hanging up on. And that's what that was this session. And it was the health committees were just dug in on it. So, yeah.
And I am glad it's a pilot. I mean, I think we're going to learn a lot from this. And, I think it's up to the Board of Pharmacies and the board of, that regulate psychology and the types of drugs that are being administered, and then to see how much of this can be replicated across the state. So I think the legislature did take, a compromise step of making it a pilot. And then now the discussion is around, what's going to be measured in the pilot and just, it's baby steps.
Agree. And I think there's all sorts of no's and yeses again that sort of like sort themselves out as these policies move forward. And so even though this is a pilot, there'll be hopefully good data that we can make better decisions on as we move through time. And we'll continue to track this very closely so that we can, ensure that our patients are protected. So thank you for that. I appreciate your perspective on that. And any thoughts on our qualified healthcare provider measure, for example? That was the one for SB 2491. That one died before JDC and WHAM before it even, I think right after crossover, it didn't get heard. But that's a measure where I heard a lot of different perspectives on this one. My understanding, and you can tell me if I'm wrong, is that the legislature largely accepted that there is a problem with our regs, that they were glad that the task force had gotten together and we worked on this for 3 years. but I think that the terminology inconsistencies, although real, there was a failure in terms of scale. It was huge as a measure and pretty intimidating, I think, for folks to try to digest in the legislative session. So that was part of the problem. The timing also, because I don't know how well the different interest groups and stakeholders were brought in, and so we had some other different kind of healthcare providers were bringing up issues near the end or near the processing. I should say it was more in the middle of the session. Any thoughts or feedback on measures like that?
Well, it was a 193-page bill. And I think, and I have to give, the Center for Nursing a lot of kudos for taking this on, because to your point, this is something, unfortunately, it's what's required to you literally have to go into the statute, find every instance where it needs to be amended and put it in the statute. And I think and again, we were very peripheral on it. We did not testify on it, and they did circulate it with us beforehand. But it was a lot to digest, and I think in a legislative process, that's probably my guess is I have no inside knowledge around the why it didn't go through, but just the amount of material to digest, and if there's concerns, it's a behemoth to have to go through.
Good word,
The-
behemoth.
the one good thing though is, bills like that, it's a process, right? Like it's rare a bill gets passed the first year it's introduced, right? So, you know, to Mike's point, Laura and her team did an amazing job pulling an assessment and analysis together. I remember she gave us a draft of it in September and she's like, "Will you please read this and give me your feedback by, October?" And I was like, "Sure, Laura. I've got some nice summer reading." But it's gone through this first crack. They've taken a couple looks at it. The bill can get split up and parsed out, and they'll come back and get something passed next session. So, you know, this is the legislative process in action, and so I give her a lot of credit for getting it that far.
Agree. Like, I think that's feedback that we've gotten as well, that it probably needs to be phased, broken up into pieces. There may be, direct DCCA review and trying to, request further stakeholder engagement. So some work that needs to still
I
happen.
mean, I remember, that was one of the, I've never seen so many departments weighing in on it
Yes.
because it touched so many regulatory bodies. And I know the testimony in some of them were like, hey, we will review this and get back to you at the next hearing, because there was a lot. But at the same time, it's work that needs to be done, right? Because I think there is a recognition for many years that the scope of work that is being done by any class of professional needs to be reevaluated with kind of quality and safety in the backdrop. But it's work that needs to be done to look at. So.
Thank you. I think we still have time. I'm really enjoying the information that you're sharing in terms of your perspective. If you don't mind, I wanted to discuss HB 1970 as another difficult measure. That's the one for UH Cancer Center, that the tumor registry. And there was, it failed to cross the finish line. Basically, one of the likely issues could have been that it was sort of occupying an awkward space politically and fiscally. Everyone agrees that the registry is important. I think that in the healthcare landscape, sometimes these registries are viewed as like background. They're not necessarily, and they're like projects on the side. They're not necessarily central to decision making. And I do think that that is part of the challenge in bringing this measure forward, just keep it in the front so that it would rise as a priority. There was also this issue with where it should be funded. Should it be funded by the state or by UH? And I wanted to hear, if I could, like your thoughts on that and ways that you might consider bringing that, pressing that forward in the future, because we still need that.
I am not. We did not weigh in on that bill, so I won't have much to add to that.
I mean, we didn't weigh in either, but this is certainly an issue. We've been involved in Queens has been involved in other registries and so forth. And I think, you can look at other states and see what's happened there. I think there's some great examples of what can work. And so just like the bill we were talking about previously, I imagine this will come up again and eventually it'll get over the finish line. So I think the education that happened this last legislative session lays that groundwork for continuing the work going forward. So, but you identified the challenges, I think, where it's housed, how it's funded. I mean, those are the key pieces that you've got to work on in the interim to get it over the finish line next year.
I think the only thing I'll add, and this is more general, not specific, a lot of the priorities that come out of the university or the cancer center, again, it shows how important it is for that to be identified within their own budgeting processes. And so I'm not certain whether this bill was in the same category, but oftentimes when bills kind of come outside of that budgeting process or that prioritization process, it gets treated differently by the legislature, because it's the way that it's supposed to work is that departments come forward and they bring forward what the priorities are, and that way you make sure that resources aren't being kind of distracted from what the department is saying. So that happens a lot in these initiatives. And again, I'm not as
Fair.
familiar with that, but on this particular bill, but I I suspect that there might have been a little bit of that perhaps if it didn't come out of that process.
Good point. Well, I want to also allow for some time so we can talk about the priorities from the hospital's perspective, because I was really impressed with the work that you guys have done in sharing your lists and the measures you're tracking. Obviously, doing a ton of work. You're the professionals. And so I wanted to hear a little bit first, maybe from JC and then from Michael, in terms of your priorities, how they were developed, and some of the wins. I did put on the slide there the state budget and the monies for Kona hospital projects as an example, but feel free to riff and freeform it.
Well, that was, I mean, I'll take the moment to riff on the budget. Queens is in this great position to be working on building a new medical campus over in Kona, which is thrilling and exciting. And I just saw the architectural renderings last week, and I mean, the community is going to be so satisfied. The state's going to be so satisfied. And the fact that we get to partner with our friends at HHSC in the West Hawaii region on building, part of the outpatient care center on our campus is thrilling. And we were so pleased that the finance chairs and the area legislators put $50 million in the budget, and it got actually funded is a huge win. And I mean, personally, it's very satisfying. And having the governor, the House and the Senate and everybody come together on something this important is one of those legislative wins that you really gives you a little, air in your sails. And so we're looking forward, now to getting to expend that and start the project, and we'll see where that ends up. So onward on that.
Yeah, I have to commend you guys. That is no small feat to get appropriations of that amount, and I think it really reflects just buy-in from all sectors, especially in a budget that's as challenging. So really great work that Queens did to get that over it, and we're really excited too to see that come to fruition. So
It's like all of the ducks are lining up so that we can really improve Hawaii healthcare. We have the rural health transformation dollars, and you can't use that money for building structures. You can't, it's not a brick and mortar funding. So the fact that you're going to have facility going up there on Big Island it's going to be the center for a lot of rural health activities. So I'm excited for Queens and for our neighbor islands. I think that's going to be so great. There are some other priorities from the budget, the QCIPN.
Sure. So we also got a nice GIA in the budget that was wonderful to help with some of the care coordination. We're thrilled about that. That'll affect all of our systems across the entire state. Another bill that I'm really happy made it over the finish line had to do with medical debt and alleviating medical debt within our state for systems as well as patients that come through. Queens has been working with a nonprofit on the mainland called Undo for a couple of years now to try to alleviate, at least to kind of alleviate the first batch of debt that we've been working on. It's about $400,000. And that was hugely successful. It took a number of years. And I think the state and the governor's office of wellness saw those successes and would like to kind of expand that on a statewide level. That helps not just our systems, but it helps everybody in the state. And so we did see that one finally get over the finish line. And we have literally been working on that for, I got at least 3 years at this point. And so that was another kind of nice crowning point.
I saw that on the list. That was really awesome
Yeah.
too. There were so many that I could have put on the slide that would just go on and on forever, but that was a really great
Yeah.
one for our state. And it's been a national problem. I'm so glad that you guys have
Yes.
been addressing. Yes. And so I have some others here listed, but we can also give Michael some time to talk about HPH and some of the priorities that you guys had.
We talked about one of our priorities, which was the fingerprinting bill, but there's a couple other bills that maybe didn't make the headlines that we were really happy to see pass. And one of them, and I don't have the bill number here in front of me, but it was the one that essentially is going to make it a lot more difficult for adolescent vaping.
Yes.
I used to be the chair of the Hawaii Public Health Institute, and I remember this is probably 5-6 years ago and we could never get any bill to regulate vaping products. We know there's just scientific evidence about the ills. We know it's being marketed specifically towards kids. We know all these things, but we've never been able to kind of crack the. They have a really strong lobby at the legislature, and this year there was a bill that was passed, and I have to give Representative Matayoshi a lot of credit for getting it over the goal line. That's going to make it a lot more difficult for retailers to sell vaping products. They're going to require a lot more verification that it's a legit product from the FDA. We just have an FDA issue now. If they bend that issue, but first things first, and this will last long after whatever we're experiencing right now. So we're really happy about that. And then there's another bill that is, again, under the radar. And I have to give, again, Department of Health a lot of kudos, as well as one of many physicians. And I like to highlight, especially for this group, kind of victories where it was physician-led in many ways, right? You have a department that was really concerned about fetal death, stillborn death, and the data that was not being collected. And it may sound like a small thing, but it's a really huge thing on a variety of issues, right? If we want to have data-driven conversations about public health, we need to have data. And this was something, when I look back at and I was working with Dr. Joy Vink, I mean, she was working on this for 2-3 years at a national level. And I was going back to emails going back to 2023, 2024, and she helped really kind of galvanize support within our organization. And so we were given our role at Kapiolani Medical Center, and what our pediatricians are now going to be required to record in terms of death certificates for stillborn death, we're going to have a much richer panel of information to make good decisions on a variety of things, right? It could be midwife licensure or whatnot, right? If we have better information, we can do this. And this is something that's probably not celebrated. You won't hear it too much, but one of those small wins that took many years to happen, and good partnership between Department of Health and the physician community in making this happen. So that'd be two.
That's so true. And we're so grateful for our OBGYN colleagues who are giving us good information, and we were able to weigh in on that measure as well. So yeah, I'm really grateful for a lot of these connections that have been pretty fruitful for us in HMA and the legislative session. And
I was just going to add on to that. Speaking of OBGYN, I think a couple of the other highlights this session had to do with people that would prevent someone accessing a healthcare center or facility. I know there were expansions in, enabling that and so forth this session that was really important. And we also expanded our shield laws a bit more this session. So in light of kind of everything happening on the federal level, I think Hawaii took a really bold step in really kind of looking out for our providers and our health systems and landscapes as well. So big kudos to the Ledge for that.
Yeah, I'm grateful to all the advocates that were kind of keeping everyone in line and nudging us and reminding us to submit the testimony and pay attention to these ones, because they were in the background and they all moved forward, and it was very exciting to see some of these get the attention that they needed. So I think that the session has been an education for me, and I continue to learn just from all of our coalition partners, from all of the different patient interest groups that we interact with. Everybody's perspective is important, but also being able to bring different groups in on measures, like bring the pediatricians in on the psychologist prescriptive authority measure, things like that, where it's not going to be necessarily the first group that you think about, but definitely impacted by that measure. So I continue to try to make those cross links to try to bring folks together.
I'll add too, I learn a lot every time I talk to somebody. We're all kind of touching the same elephant with different hands and different parts of it. But the medical societies are critical in our public policy prioritization too, right? It's going to be different from system to system. I can tell you within Hawaii Pacific Health, it's ACOG and the AAP. Dr. Maya Maxim is with us, and just given our role in pediatrics, on both on a national and on a local level, their opinions matter. And then certainly probably with you folks as well on ACOG, like we are in lockstep with them when things come up in questions about either service delivery or safety. We go to the medical societies, right? There's always this weird tension of you want to be engaged in policy, but how much of a medicine do you want in driven by policy, right?
Yeah.
It's a really yeah, you have to really thread the needle on that, right? Because
Yeah.
the people that know the most about it are, we believe, are in the medical societies, and at the same time we understand there's other stakeholders, but it's an interesting thread in this advocacy role and how you engage lawmakers while at the same time kind of retaining kind of the independence that you need to practice medicine, especially when medicine evolves so quickly. Yeah.
Again, I'm just going to keep learning and taking cues from all of our different advocates. I wish I had time to thank all of them that have participated this session and engaged on so many important conversations. I think this is a good time then to ask for a little bit of preview from you guys on what you think on what's on the horizon, what we'll be looking at in the fall, in the winter, but also in the next legislative session.
Well, I think with all of the changes happening on the federal level and all of the policy changes that are happening because of the One Big Beautiful Bill and HR 1, we are all looking towards 2027 to see what that, cliff is really going to look like. And I think Hawaii has done a decent job of at least starting to prepare for that cliff. But we just sometimes don't know how big it's going to be until we're in it. So I do think on the federal level, that's going to be important to think about. I don't know, Mike's going to talk about this a little bit, but the one big thing, the big flashing light that came out to me this session was how much AI is really going to be at the forefront of a lot of our policymakers next session. And we flirted with it a little bit with a couple of bills this last session. And I think I took away that there's just a lot of knowledge building that needs to take place between now and next January. But I don't know. What else do you think?
I agree with everything Jacce said. And then keep in mind too, right? A lot of the Medicaid cuts that are coming through OBBA, they're going to happen next year. And we're going to be a lot closer to implementation of it in a real way. On the AI piece, there were a couple of bills. Epic actually reached out to us and said, wow, this is the national policy director for Epic, and said, Hawaii punches above its weight class. We've never seen this many of bills being introduced to manage AI in healthcare than any other state in the country. So, I know, and I would say in Hawaii, we do have a tendency to overregulate initially, even before the industry develops. We actually have one of the more advanced cryptocurrency regulatory regimes, way ahead. We don't have a cryptocurrency like industry that's native here, and we don't really have an AI industry here that's native here as well. And they're aware, all of our legislators and decision makers, they go to conferences across the country. Every conference across the country has to have an AI panel. And a lot of those ideas come back and they get into fruition here. And we did have a couple of bills here that were highly prescriptive in terms of what we had to disclose to patients. And in reality, right, there's a lot of AI that is helping address physician burnout. You can probably think of tools that are being used in your practices, not in a direct patient point of view, but when bills come out, it's kind of vague. And there was one AI bill that actually does provide protection for adolescents that are interfacing with ChatGPT like services from a behavioral health perspective to protect that. So, but I think AI will continue to be. And then I think the second thing is the changing landscape on drugs on the federal level, right? We saw a bill this year with cannabis use on hospital premises, and what's looming in the background, right? We had 2 executive orders in the last year. one that had to do with psychedelics and taking them off of a scheduled substance for research value. More recently, with Joe Rogan's help. And that's how policy is done, folks. You get, I won't go off on that. But anyway, we had that. And then we also had a different treatment of marijuana and cannabis. So as I think we start to see the relaxing of maybe the criminality elements of those scheduled substances, the attitudes towards them are going to change. And it's going to be really incumbent upon the medical community, if there are concerns about that, to raise them and address them if we have to start to chart our own way in this area. So I'm just going to put that out there for HMA as well.
Maybe just one other little tidbit here, and this is a bit higher level, but I also am a little concerned, and as I look to the future, we are all being asked to do more with less, and the state's no exception. And I think some of the financial struggles that the state is going to face and continues to face is going to catch up with us, especially when you think about what state departments are asked to do for the public and for professional organizations, whether you're looking at licensing, whether you're looking at preparing for the next epidemic. I think there's a lot of concern and a lot that we still need to do in terms of planning to make up for those shortfalls, and that still gives me a lot of hesitation there. So, not to go out on a down note, but it is something to have us all think about. Yeah.
Well, I've really enjoyed hearing these perspectives and also this little preview of the future. I think it demonstrates that there's a lot of work to do and a lot of conversations that need to continue and need to happen all winter, continuous, all the time on texting and emailing and such. But I'm so grateful to have had you guys here to talk. I want to give our audience some time. I know that we have a few minutes. If there's a question or two in the chat, no, any comments from anyone in the room that wants to talk? If not, we can close it up. And I just want to thank you guys again for being here for HMA, and we're going to continue to reach out to you as resources. We're so grateful for the work that you guys do.
And I want to thank you too. I mean, both Jacce and I have been, we've been aware of HMA, and I think this is the first time we've been included in conversations, and we were really excited about doing this. And, I have to thank Dr. Tensal really for really wanting to bridge the gap. I hope that your members appreciate and understand. We're going to have differences, but there are a core set of common goals that healthcare systems and independent physicians can work together on. And I think the more we can work on the things that are of common interest, the higher likelihood we're going to push things, over the goal line. And I have to credit you folks for bringing HMA to where it is today, to where, Queens and an HPH are being invited to talk. This would not have happened 7-8 years ago. And we're really happy to be a part of this.
Thank you so much. I mean, it's an exciting time. We all have to work together. So we're grateful for your work and being able to have conversations with you too. So thank you.
Thank you.
All right. Well, thank you to our audience, and we're going to close it. Thank you for joining us this evening. Aloha.